and how to protect joints as we age. So before we start, I wanted to let you know if you have questions for Dr. O'Dell, please feel free to type them in the chat box. If you're on the Zoom and if you're viewing us from Facebook, feel free to type your questions in the comment section and we'll get to them after the presentation. And also make sure you send to all panelists. Next, I would like to introduce my wonderful co-host from the city of Arcadia, Ms. Kathy Bernal. Kathy organizes community events at the Arcadia Community Center. Kathy.
Thank you, Faye. The City of Arcadia has partnered with Methodist hospitals for many years, and it's been a great partnership, and I'm very thankful for them for providing us with all the expertise of their doctors. So thank you, Faye.
Of course, Kathy, thank you. It's our pleasure to partner with you as well. Next, I would like to introduce a special guest, Mr. Cliff Daniels. Cliff is the Senior Vice President and Chief Strategy Officer at Methodist Hospital. And Cliff will share with what's happening at Methodist. Cliff.
Thank you, Faye. I won't take up much of your time here. I know everyone here is anxious to hear from Dr. O'Dowd. But just wanted to give a brief update about the goings-on at Methodist Hospital. We seem to be we are fully operational and fully recovered from the last surge of COVID-19 in the winter. The hospital remains fully. We have all our services open. The emergency room is open. We are allowing visitors in the hospital once again, and not fully at pre-pandemic levels yet, but getting there so that we can get back to a sense of normality. I also wanted to give a brief update on the orthopedic program that Dr. O'Dowd is part of here at Methodist Hospital. Although when you look at him, Dr. O'Dowd seems very young. He is a very highly experienced, fellowship-trained orthopedic surgeon and a significant contributor to our joint replacement program here at Methodist. We participate in the comprehensive joint replacement program that Medicare has mandated for hospitals in Los Angeles County, and we have thrived underneath that. We have reduced lengths of stay. We have achieved quality metrics that I think are unsurpassed by many hospitals, and that's, again, thanks to the contributions and participation of Dr. O'Dowd and others in our orthopedic panel. So I want you to know that as you listen to him, know that you can come and seek his advice clinically with confidence, knowing that not just Dr. O'Dowd, but a full team of nursing, other clinical experts here at Methodist remain ever available to provide the highest and safest care that you could get anywhere. So with that, Faye, I'll leave it to Dr. O'Dowd to carry the day, and I'm going to excuse myself if I could to join another call that's starting right now. So thank you, everyone.
Bye.
Thank you, Cliff.
Bye, Cliff. Take care.
So now, without further delay, it is my pleasure to welcome Dr. James O'Dowd. Dr. O'Dowd, take it away.
All righty. Good morning, everyone. Thank you for tuning in. Thank you to Methodist Hospital also for hosting this, and for Faye for setting up this lecture. So I'm James O'Dowd. I'm a orthopedic surgeon. I'm with Congress Orthopedic Associates. I'm talking about joint health today. So a little bit about my background. So my subspecialty is called adult reconstruction, which for the most part means hip and knee replacement, the management of end-stage osteoarthritis of the hip and knee, and then also revision joint replacement in the rare situation where a joint replacement has a problem. So I did 4 years of medical school at Loyola Chicago Stritch School of Medicine. I did a 5-year general orthopedic residency at USC here in Los Angeles, and then I did a 1-year fellowship in Houston at the Houston Methodist Hospital there, doing a year of joint replacement surgery. So here's an outline of my talk. I'm going to try to answer a few questions for everyone. So first, what is a joint? What is arthritis? How can I protect my joints? Can I prevent arthritis? What are treatments for arthritis? And what are the surgical treatments for arthritis? Minimize that there. Okay, so first, what is a joint? So a joint is simply a connection between two or more bones. In the case of the knee and the hip, which is what I'll focus on today, it's the site of motion between two cartilage-capped bones. So the knee joint is here on the left, and that's the joint between the distal femur, that's the thigh bone, and the proximal tibia, that's the leg bone. And then out front, we have the patella, or the kneecap. The hip joint is pictured here, and that's more of a ball and socket joint. So the ball portion is the top portion of the hip bone, or the femur, and that's the femoral head. The femoral head moves within the hip socket, and that's part of the pelvis called the acetabulum. So those are the two joints that I work on, and the two joints we'll kind of focus on today for our talk. So let's go through a little X-ray review here first. So this is a normal knee X-ray, and you can see at the top here that is the distal femur, and at the bottom that is the tibia, that's the leg bone. Now this space in between, I'll see if I can zoom in here for you. So the space in between these two bones, that's the cartilage, and it shows up as a space because it doesn't show up on X-ray. And so in healthy joints, you see this nice space that's roughly a centimeter wide that's filled with healthy cartilage. And so we'll look at some arthritic later on, and we can kind of compare the difference. But that's your knee frontal view, or the knee AP. This is a knee X-ray looking from the side. So again, you see now you're looking at the side view of the femur and the side view of the tibia. You can see the joint space there. And then in the front is the kneecap. And the kneecap also has cartilage behind the kneecap. And now here's a pelvis X-ray. This is an AP pelvis X-ray. You can again see you can kind of appreciate the ball and socket joint here. You have the femoral head articulating with the acetabulum, which is part of the pelvis. And we can kind of do that same zoom in trick. And we can see in this is a fairly normal X-ray, and you can see this is the cartilage in the hip joint. There's a space there that in a healthy hip joint is maintained. And we'll come back to that later again. So that brings us to arthritis. So what is arthritis? And arthritis just means inflammation of a joint. And then what is inflammation? So inflammation is a very complex biological process, but ultimately inflammation leads to pain, tissue breakdown, inflammation, or swelling rather, and increased sensitivity. There's multiple types of arthritis, and the type that I'll focus on today is osteoarthritis. And that's the most common type worldwide, the most common reason for patients to come in with arthritis. But it's important to know that there's other types of arthritis as well. There's autoimmune arthritis. Most of you have probably heard of rheumatoid arthritis or lupus arthritis, and that's when the body is actually attacking the joint surfaces directly when the immune system is not functioning properly. There's also gouty arthritis, and that's another more uncommon form of arthritis where crystals actually deposit within a joint space and cause pain. And in very rare cases, there's bacterial or septic arthritis, and that's another way bacteria can actually get into a joint and cause an arthritic process. So osteoarthritis, osteoarthritis. So what is osteoarthritis? It's the deterioration of cartilage within a joint that leads to pain, stiffness, and dysfunction. So this is kind of the microscopic view of osteoarthritis. We'll start here. And you can kind of see this is the normal cartilage. And this big, thick purple layer, that's healthy cartilage tissue. And underneath that is normal bone. But this layer here, you can see it's nice and smooth and thick. That is the kind of a cross-section of healthy cartilage at the tip of the caps of your bones. Now, if we kind of move over here to see the damaged articular cartilage, this is what ultimately happens in osteoarthritis. Through inflammation, through wear and tear, you get a breakdown of that thick purple layer, develop all these fissures and cracks, and this leads to a joint surface that's no longer smooth, no longer comfortable. And then you can see down here, there's changes that happen in the bone as the cartilage wears off. So what does osteoarthritis look like on X-ray? So remember, on the left side of my screen is a normal knee X-ray. And remember, we have those nice spaces between the femur and the tibia. If we look over here on the right side of my screen, you'll see an arthritic knee. So it's pretty easy to appreciate that in this knee on the right side of the screen, there's bone-on-bone contact. That space is lost, at least on the inside of the knee. And this patient has what we call a varus deformity or bow-legged deformity. Another X-ray of arthritis, so normal again on the left, preserved space between the femur and the tibia. On the right side of my screen, you can see you can see that this is now bone on bone. So you can see that in this patient, it's the outside of the knee that's worn in. And in that case, we call it knock-knee deformity or valgus deformity. So not too hard to pick these end-stage osteoarthritis cases out. So here's the lateral view or the side view of the knee, normal on the left. On the right side, you can look behind the kneecap and you can see there's no longer space there. And you also have these big bone spurs. That's another process that happens with arthritis. And that is pretty easy to recognize over here. You can see bone spurs behind the kneecap, bone spurs in the back of the knee, and that is what we see typically in an end-stage arthritis case. Similarly, in the hip joint, so for this hip, you can look to the left side of your screen as the normal hip. And there we see a smooth femoral head. That's the ball part of the hip socket. And then you see intact cartilage space up above. But on the other hip, you can appreciate that space on the top is now gone. There's now bone-on-bone contact between the femoral head and the acetabulum there, and that's end-stage arthritis of the hip. That's what that looks like on X-ray. And this is just the zipper and the button the patient was wearing pants during that X-ray. So, what causes osteoarthritis? And this is a tough question. It's not just a single thing that causes osteoarthritis. It's multifactorial. There's many factors that lead to osteoarthritis. So some of the risk factors, one of the risk factors that's not something that we can change, but is one of the major, probably the most significant risk factor for osteoarthritis is aging. So wear and tear over many years can lead to the breakdown of the articular cartilage and subsequent inflammation. And we also know the cells of the cartilage and in the knee are with aging, are less able to protect themselves and more likely to wear out. So aging, starting around age 50 is where the osteoarthritis starts to kind of show itself. We know that over 30% of adults with age 65 and over actually have some form of osteoarthritis somewhere in their body. So that's a big one. And that one we can't change is the aging process. Mechanical factors are also involved in causing osteoarthritis. So bone geometry, that's kind of how that's again something that usually cannot be changed. Is how your leg is shaped, whether you have a knock-knee pattern to your knees or whether your knees bow outward, a varus deformity. The other mechanical factor that's a big one, and this one I'll come back to because this is a modifiable risk factor, is the body weight. So body weight, excessive body weight puts additional pressure on our joints, and that additional pressure can cause pain in an arthritic joint and probably leads to earlier degradation of the joint. So even small increases in body weight lead to big increases in the force across the knee joint. So one of the things I usually tell my patients that if you lose 5 pounds from your body weight, you're actually unloading your knee by 20 pounds because of the forces of the femur, the lever arms. The weight gets multiplied. And we'll talk a little bit more about that later. So genetics are involved in osteoarthritis, but it's not something like hair color or eye color. You don't get it directly from your parents. There's multiple genes that contribute to osteoarthritis. Just because your father had osteoarthritis does not mean that you're going to get it for sure. It probably increases your likelihood, in the 30 to 40% range. But it's not something that's passed directly down from parents to children. So injury can also lead to osteoarthritis, but this is not injury like bumping your knee in the hallway. Typically, we think of injuries like breaking the bones around the knee at some point or breaking the ligament in the knee. Those can alter the mechanics within the knee joint and lead to premature osteoarthritis. And gender, unfortunately, is also a risk factor, at least in the knee osteoarthritis. Women tend to have a higher rate of osteoarthritis than men in terms of the knee and the hip. The rates of osteoarthritis are very similar.
爸爸，你声音放大了哈。
So, but it's important to know that osteoarthritis is not just unique to human beings. If you go to the Natural History Museum, you'll probably see some of the specimens on display have arthritic changes in their joints. So this is something that happens to all different types of animals who have skeletons, who have joints. So it's not unique to human beings. But we'll get on to the more practical part of the talk. So this is how can I protect my joints? So like I alluded to, maintaining a healthy body weight is probably the biggest thing you could do to protect your joints. As that having excessive weight likely leads to an earlier breakdown of your knee joint and leads to more painful symptoms if you do have osteoarthritis in the knee. So maintaining a healthy body weight is really one of the key things that you can actually change to protect your joints and to prevent the development of painful arthritis. So it is important to stay active. Your joints like motion. We say motion is lotion. The joints tend to feel better when they're moving. So I recommend low impact exercise for my patients who have arthritis and who want to protect their joints. So that would be kind of the elliptical machine, stationary bikes, swimming. Those are the kind of low impact activities that tend to be more joint friendly. And that's as opposed to running or playing tennis, which has a lot of impact, is not as joint friendly. So there's some scientific evidence that an anti-inflammatory diet can help keep your joints more comfortable. And an anti-inflammatory diet is you might be familiar with. It's a healthy diet. It's a diet that's high in fruits, vegetables, fish, and whole grains. That's low in processed foods that may contribute to inflammation. And another way to protect your joints is just to avoid injury. You do want to avoid falls. You want to avoid injuring the ligaments around the knee. So that's another important part to protect your joints. So the treatments for arthritis, I'll go into that a little bit here. So the goals of treatment for all our treatments for arthritis is to minimize pain, optimize function of a joint, optimize the range of motion, the strength around the joint, and when possible, to slow the progression of joint damage. But let's see. So first I'll start with non-surgical treatment. And what we typically recommend for all our patients with early or even moderate arthritis is physical therapy. And physical therapy is working on strengthening and stretching the muscles around a joint. The principle of physical therapy is that by strengthening the muscles around the joint, you can actually unload the joint, make the joint more comfortable just by strengthening those muscles. And we find a good number of patients get relief from physical therapy. Weight loss, again, if for people who are overweight, 10% body weight reduction can lead to a 50% reduction in pain. So that's a significant effect. Assistive devices can be useful. So for our patients with more advanced arthritis, a cane and walker helps them stay mobile, helps them avoid falls. We also have a number of braces, knee supports, and there's a variety of those. And they're not appropriate for everyone, but at the very least, a neoprene sleeve is often enough to provide a little extra comfort and support. What I don't have on here, and I should have, is icing. Icing is very helpful to an arthritic joint. Usually ice twice a day for 30 minutes at a time. Usually after activity is the best time to ice your knee. That's something I didn't have on here, but that's can make a big difference in keeping your joints comfortable, reducing swelling, and that kind of problem. So now going to the medications, I'll start talking about the topical medications, or what usually we recommend first. These are kind of the safest medications to apply. They do not have any systemic side effects for the most part. So one of the ones that I typically recommend is called, the brand name is Voltaren. It's a diclofenac, and this is basically a topical Aleve or a topical Advil. It's a topical NSAID. So this used to be a prescription medication, this Voltaren, and then in the last year has actually become available over the counter. So this is something that you can apply 3 to 4 times a day directly to the painful joint and can significantly reduce pain and swelling. Other topicals, there's capsaicin that has shown some benefit in treating osteoarthritic pain. Capsaicin contains capsaicin, which is the active ingredient, in your pepper sprays and your hot sauces, but it actually has effect to reduce pain in the joints and reduce the sensitivity of nerves. And then there's a whole other array of topicals that some patients find effective. This is like BioFreeze or Icy Hot, Bengay, and those are topical cooling agents like menthol, and then topical anesthetics like lidocaine. And those, when applied to a painful joint, can also improve joint comfort. CBD creams are becoming more popular, and they're not recommended by the Orthopedic Academy, but they are safe, and for some patients they really do reduce the pain and help reduce irritation of the nerves. So that's something that could be tried. So next level after topical medications, you have oral medications. The class of medications that we usually recommend first are the NSAIDs. So NSAIDs are non-steroidal anti-inflammatory drugs.
是什么来的？
And I have them listed there. So the
Right,
over-the-counter
NSAID.
ones are typically ibuprofen or Advil or Motrin, which is the same.
NSAID.
Ibuprofen is the same as Advil or Motrin. And then you have naproxen, which is Aleve. And these are anti-inflammatories that you can take before aggravating activity, before activity, and these can often improve the comfort of a joint, reduce inflammation quite a bit. There's also prescription NSAIDs that we can prescribe that can be very helpful. Tylenol is another medication. Tylenol is acetaminophen. That's another medication that our patients find healthy in managing the pain of arthritis. And Tylenol is a very safe medication. You can take up to 3 grams daily. And Tylenol can actually be taken at the same time as ibuprofen and naproxen because they're different. They have different mechanisms of action and they're processed differently by the body. In terms of prescription medications for severe osteoarthritic pain, we will occasionally write prescription medications that are narcotics. Tramadol is the narcotic that's recommended by the Orthopedic Academy, and that's a strong opiate medication, but it is very effective at reducing severe pain. So the oral medications can be very effective, but you always have to mention side effects. So the NSAIDs can irritate the stomach if taken for a long enough time or in certain sensitive individuals. And they can also not be great for the kidneys if you have pre-existing kidney problems or you take these medications over a very long time. They can actually irritate the kidneys. So that's something to be aware of for NSAIDs. Tylenol, again, very safe medication as long as you keep to this 3 gram daily limit. But Tylenol is very safe when taken at the appropriate doses, and that's important to realize. Tramadol, the strong narcotic pills that we sometimes use, are they're opiates, so they are addictive, and patients can develop a tolerance to them. So, we have a lot of questions about supplements, and one of the supplements that's actually shown evidence of improving joint comfort and helping to treat osteoarthritis is turmeric. So turmeric is this plant. It's a relative of the ginger plant, and it's available in all sorts of different formulations. The active ingredient of turmeric is this curcumin complex. And so this turmeric, very safe supplement to take, and a lot of patients find it helpful in reducing their pain. So that's something that that would be safe to try. There's other supplements you'll hear about: glucosamine, chondroitin, collagen peptides seem to be the newer things coming out of the market. And from the orthopedic surgery perspective, we tend not to recommend for these supplements. There's limited evidence, but they are safe. They don't have side effects, and some patients do think that they benefit from them. So it's something that you can try. That you'll be, that obviously have to pay for, but it's something that doesn't typically cause side effects. So it's certainly okay to try these supplements. So, kind of moving up the ladder of treatments for arthritis, the next, after oral medications and physical therapy, what we next consider are injections. And injections are given directly into the arthritic joint with a needle. And there's a few different types of injections we have to use for arthritic joints. So what you'll hear commonly about is steroid injections into the and that's corticosteroids. So these are powerful anti-inflammatories. These are the ones here that we're injecting directly into the joint. Commonly, you'll hear about this is methylprednisolone or triamcinolone. These are medications that go into the affected joint and they reduce inflammation. They can significantly reduce pain and discomfort, but the effect tends to be temporary and it lasts. The duration of how long it lasts depends on exactly what's going on inside a person's joint. For some people, a steroid medication may provide pain relief for months or even up to a year. For others, it may only provide a few weeks of relief. You may also have heard of lubricant injections. So lubricant injections are hyaluronic acid, and that's a component of normal synovial fluid and also a component of healthy cartilage. And that's, and that's pictured up here. This is a clear gel that we actually inject directly into the knee. It has lubricant properties. It has anti-inflammatory properties. It is covered by Medicare twice a year to be given to the knee joint. And a lot of patients get great relief from this, and it often is more longer lasting than the steroid. The other medication type that's shown benefit for osteoarthritis is PRP. You might have heard of that. That's platelet-rich plasma. So that is an injection where we actually will withdraw blood from your arm, and then we'll take the blood. We spin it in a centrifuge to extract this the platelet-rich portion. The platelets are involved in blood clotting, and they actually have anti-inflammatory properties. And this is something that's not right now covered by an insurance to be used for arthritis, but it has shown good effect in relieving the pain of an arthritic joint. So that's something that can be done, but unfortunately not covered presently by insurance. So the last resort, if we tried all these things, last resort in the treatment of arthritis is surgery. And for end-stage arthritis of the knee and the hip, that is a joint replacement procedure. So total knee replacements are more common than total hip replacements. Total knees are performed 700,000 times per year in the United States. Total hip replacements not far behind at 400,000 per year in the United States. And that is projected to rise with the age of our population. We are expecting more patients to be requiring joint replacement. So when should I consider joint replacement? And this is an important question. So generally, a joint replacement, it's an elective procedure. The doctor doesn't tell you that you need a joint replacement. You tell the doctor when your symptoms are so severe, when they're affecting your life, that you are ready for a joint replacement. In certain cases, I will tell a patient that they should have a joint replacement sooner rather than later, but that's not the case. Usually it's up to the patient. Pain is a question we ask. Is the pain preventing you from enjoying your life and from carrying out your activities, your shopping, you're going for a walk around the block, putting on your shoes and socks, those kind of things. Another question I usually ask is, how far can you walk comfortably? If you can still walk 2 or 3 miles and you're not without too much pain, you probably don't need a joint replacement. But if you can walk only a block or a couple blocks and your knee hurts with every step, that's when, or your knee or hip hurt with every step, that's when a joint replacement can really be helpful. And then does the pain wake you up at night? When arthritis gets really severe and advanced, it actually wakes our patient up. So sleep is very important to good health and to overall well-being. So if the joint is starting to affect the quality of sleep and it's waking our patients up, that's another kind of signal that we might be ready for a joint replacement. So total knee replacement is the treatment of choice for end-stage arthritis of the knee. And so this procedure, here's my zoom in trick again. So this procedure involves, it's called a joint replacement, but it's really a joint resurfacing. What we do is remove the affected arthritic joint surfaces and replace that with a pain-free, very durable metal and plastic component that provides for a pain-free joint. So in the femur, we're only taking less than a centimeter of bone off the femur, and on the tibia, we're only taking about a centimeter of bone. We also resurface the back of the kneecap. So I would think of this procedure as a resurfacing, not as a complete replacement of a large portion of your body. And so the goal of this procedure is to give you a pain-free joint and to get you back to hiking, biking, golfing, the activities that you enjoy doing in your daily life. The procedure typically lasts less than 2 hours. We allow immediate full weight bearing on the knee replacement. At Arcadia Methodist, we usually do a one-night hospital stay after the joint replacement, where you'll work with physical therapists and receive some medications. And this is what the component down here, these are the actual knee replacement components. And one of the very common questions is, how long will a knee replacement last? And that's a difficult question to answer, but in over 80% of cases, the knee replacement lasts 20 years or more. So this is I usually tell my patients they can expect 20 years or more from a modern knee replacement with modern materials. This is a very effective surgery for end-stage arthritis of the knee. So this is a knee replacement that I completed recently, and you can see here the femoral component. That's over the end of the femur, and this is the tibial component, and that's over the tibia, and that's fixed with this. You see that this white area here, that's actually bone cement. And so that's the gold standard way of how we actually affix these components to the bone is with bone cement. And that gives you an immediate rock solid fixation of the implants to the bone. So then total hip replacement, similarly, treatment of choice for end-stage arthritis of the hip. And in this procedure, we're resurfacing the hip socket on the acetabulum. We put this component in there. And then we also remove the affected portion of the femur and the femoral neck, and we put this component down into the thigh bone. So again, the goal is to create a pain-free articulation. The total hip replacement, we don't use bone cement. The bone actually grows into these components, and generally, it's a very, very successful procedure. So this is a less than a 2-hour procedure. It's, again, a one-night hospital stay when you do this at Arcadia Methodist. You walk on it the same day. It's very similar to the knee replacement. This procedure, one of the most successful procedures in orthopedics and in surgery in general. We have 90 to 95% patient satisfaction rate. These hip replacements last even longer than knee replacements. So I usually tell my patients about a 30-year expectancy that these implants will last. So here's a hip replacement that I performed recently. This is the x-ray that we kind of looked at earlier, and you can see the metallic component here in the hip socket. And then this is the femoral component, and that's inserted within the femur, and the joint is there. Okay, so these surgeries are very successful. I feel very confident offering them to my patients who have end-stage arthritis of the hip and knee, but it's important to mention the risks of surgery. So I usually mention a 1 to 2% risk of infection with these surgeries. There is a slight risk of blood clot that can happen in the legs with hip or knee replacement. Very rarely, patients develop stiffness. That's more a problem in knee replacement. Some patients can have ongoing pain, but that is rare. And implant failure, if the implants were to wear out or loosen in some cases, that is also very rare, but important to mention that can happen. So some of the advancements in joint replacement that I wanted to mention, most significantly is probably the material science. The manufacturers and the designers of these implants have improved the quality of the components we're using. Actually, the plastic has been advanced the most probably in the last 15 years. So the plastic we're using today is extremely, extremely durable and resistant to wear, and that's why the joint replacements we're doing now are lasting longer than joint replacements have in the past. And so that's really good for our patients. Mm-hmm. The implant geometry has also improved. So now we're putting in implants that are now more closely matching to the native anatomy, your natural anatomy, and that usually provides a more comfortable and more natural feeling joint for our patients. Surgical technique has improved as well over the past 60 or more years that this procedure is being done. So we have minimally invasive techniques now. We're making smaller incisions. We're having less blood loss. We do have tools available like computer navigation and robotics that help us to be even more precise with our component placement. Our post-operative protocols are also much improved, so we're getting our patients up and out of bed faster and with less pain, and getting out of the hospital within one day back to their home, where they'll work with a home physical therapist. Our anesthesia techniques have also improved quite a bit, so now we've kind of figured out the ideal way to give anesthesia during these procedures so that you can get up and walk the same day and that you're not feeling extremely nauseous or uncomfortable after a knee replacement procedure or a hip replacement. So let me just go through this is my last slide, just some key points from my talk. So for joint health, you want to stay active. You want to stay active with low impact exercises. That's the elliptical and swimming, things like that. Very important to maintain a healthy body weight to unload the joints and help increase their longevity, reduce pain. It might be helpful to eat an anti-inflammatory diet with minimal processed foods. There are a number of medications that we discussed that you can use those strategically to before and after activity to control your symptoms, and to consider surgery if your life is significantly impaired by joint pain. That surgery generally is very, very successful, and generally we have very satisfied patients who wish they did their surgery earlier. But thank you all for your attention. these are my contact information below. I'm happy to take any questions that you might have.
All right. Thank you, Dr. Odell. We do have some questions that we collected from the chat box. So let me read the first question for you. So this audience is saying that it's not really a joint question, but this issue affects her joints. So she asks, certainly my exercise of said joints, what is the best way to deal with pain and stiffness in the fascia across the top of the feet? This pain and stiffness has the effect of inspiring me to go out for fewer walks when it's acting up. Should I go walking anyway?
This is a question about the feet, about fascia, sounds like maybe some plantar fasciitis or some pain at the soles of the feet. That's a very common problem that can develop in the feet and can impair your ability to walk. Yeah, so for that, usually we recommend stretching exercises. You can do calf stretches. There's devices you can buy that are called rollers, and you can actually roll out the bottom of your feet before walking. So that's something that can be helpful. And if you go onto the American Academy of Orthopedic Surgeons website, you can look up plantar fasciitis or come in to discuss more about that. But yeah, that can be a nuisance. Plantar fasciitis is a very common problem. It's a nuisance, and it can be difficult to treat. If the pain, I do want my patients to stay active. I think it's okay to push through some mild pain in order to stay active. The alternative of lying down all day is just not acceptable as we get older. So pushing through some mild discomfort, especially if it's just in the feet, is usually okay. You should choose the activity.
Thank you, Dr. Odell. Here's the next question. Could you discuss meniscus tear?
Yeah, that's a very good question. I didn't include that in my talk, but let's see. So let's pull up an X-ray here, or how about let's pull up this initial. So the meniscus, So the meniscus is a ring of fiber cartilage, and so the meniscus is not actually pictured in this model, but the meniscus is a rim of fiber cartilage that's attached to the top of the tibia bone. And there's one on the inside called the medial meniscus. There's one on the outside called the lateral meniscus. And the meniscus is involved in cushioning and supporting the joint and providing for smooth motion. And in the process of arthritis, typically as the joint wears out, the meniscus does become degenerated. As the joint and the cartilage starts to wear out, the meniscus gets small tears in it. And oftentimes it is those meniscal tears that are actually causing the symptoms. And so in certain cases, if the arthritis isn't too advanced, we can do procedures directly on the meniscus, whether that is, a arthroscopic surgery, that's surgery using a camera inside the knee to clean out the meniscal tears. So in patients who don't have very advanced arthritis, that is a treatment of the meniscus can be effective. So yeah, it is tied into arthritis. I'm happy to answer any more questions on that one.
Thank you, Dr. Odell. The next question is arthritis prevalent in athletes or dancers?
As in more prevalent, we know arthritis happens to both competitive athletes and non-competitive athletes. Athletes who have had a history of joint injury, if they had an ACL rupture when they were younger, they do develop arthritis at a higher rate. We know that there is a higher rate of osteoarthritis in people who labor for a living, who have done a long career of heavy labor. But it's not something that's directly tied into your activity level. There's some people can run marathons their whole lives up to their 60s and they never get arthritis. So it's not something that, if you were a competitive athlete, you're absolutely going to get arthritis. But we do know there are some risk factors, like doing a manual labor job that has a higher rate of developing arthritis.
Thanks, Dr. Odell. Our next question is, what is the difference in the action between Tylenol and Advil?
Good question. Yeah, so go to the slide there.
Tylenol.
So Advil is ibuprofen. That's one of the non-steroidal anti-inflammatories, and that inhibits the non-steroidal anti-inflammatories inhibit two enzymes called the COX enzyme, and Advil actually works throughout the whole body to reduce the activity of the COX enzyme, which contributes to inflammation. So ibuprofen it's an anti-inflammatory. It works directly at the various sites of inflammation. Tylenol, it's not an NSAID, though it does have some activities on the COX enzyme, but Tylenol actually works in your brain. Tylenol is it's a fever reducer that works on the brain, and then it reduces pain by actually working centrally in your brain. So it's not working at the site of pain or at the cause of pain, but it is reducing the intensity of it. So that is a good question.
Thanks, Dr. Odell. Next question. Could you explain in which circumstances we should use ice and when to use heat?
Right. Yeah, that's a common question, and there's not an exact science to that. But I usually recommend at least incorporating some ice. I'd especially after activity. So if you go for a walk, you want to ice afterwards. And then if you do want to use heat, I would alternate icing and heating. I think just putting heat on a joint, especially if it's very sore and stiff, is not necessarily beneficial. So I would alternate icing and heating. I usually recommend for icing, 20 to 30 minutes of icing at least twice a day. And then you can alternate that with heating. For some people, if they wake up stiff in the morning and they've had, the joint isn't hurting too bad, heat can be used. But I tend to recommend, I'm more a fan of icing, after activity, after your long walk, after you do physical therapy or an exercise, something like that.
Thank you, Dr. Odell. The next question asks, what are your thoughts on stem cell therapy? I heard that if you have a knee replacement, you would not be qualified to be considered for stem cell therapy.
Yeah, so stem cell therapy, that's a growing area of research in arthritis. Right now, there's no evidence, there's no stem cell that's out there that will reverse arthritis. I recently read a study about bone marrow aspirate or stem cells that are taken from the bone marrow, and they when those are injected into the knee, they do have some effect, but this is not an effect that reverses arthritis. It's kind of similar to the other injections we have. In this study, it was actually equal to the effect of this platelet-rich plasma, which is a type of injection. So maybe someday we'll figure out how to use stem cells more effectively to reverse arthritis. But right now, there's nothing out there. It's not covered by insurance, so it tends to be the stem cell therapy tends to be very expensive, and the results are variable. So it's not something we're doing kind of on a regular basis. And the knee replacement, after a knee replacement, we don't typically do any injections after a knee replacement. So you wouldn't need a knee replacement. All the affected after a knee replacement, you wouldn't need any injections. All the affected arthritic cartilage is gone after a knee replacement.
Thank you, Dr. Odell. Our next question is, how long do you need to take antibiotics for procedures like dental work, dental cleaning, and future surgeries after hip replacement surgery?
That's a good question. Yeah, so after hip or knee replacement surgery, we generally do recommend for invasive dental work that you take an antibiotic about an hour before the procedure, and that's just to prevent bacteria which could get into the bloodstream during dental work, to prevent that bacteria from potentially landing inside of your joint and causing an infection. Now, there's some controversy about that. If you actually look at the science, it's not a strong evidence-based practice, but it does, make sense based on the fact that we know that dental work can cause bacteria to get into the blood. So I typically use that as a lifetime. So for the rest of your life after a joint replacement, if you're having major dental work, not necessarily just a cleaning, but if you're having a tooth pulled or a feeling something
把你听了
major,
哈，
you should
是
take
一个蛮重要的这个
antibiotic
快讯， 就
an
是你
hour,
做
an hour
了
before
replacement 以
the
后，那
procedure.
个
Usually
dental
that's
的 work，
amoxicillin,
他
2
就是说
grams,
好像会
1
有
hour
细
before the
菌会跑
procedure.
到那个，
The rest
等
to
等
your
你会
life.
倒回去听吧，我不是很懂。
Thank you for explaining that, Dr. O'Dowd. Here's another question. We received many questions, so let's get to them one after one.
No problem.
Okay. I had a hip replaced back in 1992 that gives me trouble now. Do I have options?
Yeah, absolutely. So 1992, that's a long. You've had the hip in for almost almost 30 years. So with the plastic that we were using back then, you could be having some wearing of the plastic components in the hip replacement. So if it's started to give you trouble, you definitely should come in to see a joint replacement specialist and get some X-rays and be examined, because there are things that can be done to if the joint replacement is failing or the plastic is close to completely worn out. It's better to catch that early so the plastic can be changed out in a surgical procedure. So I would recommend getting evaluated by
哇，好可怕！
an orthopedic surgeon.
Thank you for the recommendation, Dr. O'Dowd. The next question says, I'm taking an estrogen blocker for breast cancer. How does that impact risk for arthritis and joint health?
That's a good question. Generally, those medications, they can affect bone density. They can affect bone density because as the estrogen hormone is involved in supporting bone density. I'm not aware of any effect they have on arthritis. Arthritis is not really related to bone density. It's more of arthritis is a cartilage issue. So, while those things may not be the greatest for your bone density, I don't think I know anything about them affecting joint health.
Okay. Thank you, Dr. O'Dowd. Our next question is, I had hip replacement 18 years ago. The doctor used a special table. After the surgery, there was no worry about this replacement sitting, etc. No physical therapy even, just walk. Do you do this type of surgery?
Yes, you might be talking about anterior approach hip replacement. That's done on a special table. And it's a very stable. It's the main advantage for me of the anterior hip replacement. We get to use imaging during the procedure that allows us to put the components in very precisely, and also has a very low dislocation risk. So anytime we do hip surgery, there is a risk of the hip popping out of socket. It's not going to be as stable as your natural hip, but the risk is very low. And with the anterior approach, the risk is extremely low of dislocation. Physical therapy is generally not essential after hip replacement. Hip replacement, like your doctor told you, it's just about walking. The most important thing to do after hip replacement is walk. And as the tissues heal, you usually make a good recovery. And the goal is to have a forgotten hip, that you forgot that you ever had this hip replacement done. But yes, I do that type of surgery. It's probably referring to the anterior approach hip replacement.
Thank you, Dr. O'Dowd. And I believe this is the last question that we have. And it says, after having hip replacement surgery, and if no one falls, can one get a hip fracture on the surgery hip?
Can you get a hip fracture around your hip replacement? That's a good question. And the answer is, unfortunately, yes, you can. The bone can still break around the hip replacement. That's why avoiding falls is definitely important after you get a hip replacement. But we have techniques that problem has occurred with more hip replacements being done, and so we have pretty good techniques for fixing hip fractures around hip replacement. That's one of the procedures I do. So we have the joint replacement subspecialist. We have a lot of techniques that we can use. That does happen, but definitely want to avoid falls, avoid breaking your hip.
这是什么声音啊？
Hello?
That's it.
Hi, Kathy.
Hi.
Dr. Odell, are you there? Seems like we're having some technical issues with our audio. Let's please be patient with us. Let's see if Dr. Odell can get back online. Please be patient with us.
Can you ask him a question for me?
Sure, Kathy.
Ask him what he feels about partial knee replacement.
Sure. Okay,
Thank you.
sure. You're welcome. Okay, everyone. Looks like Dr. Odell is disconnected from our meeting. Let's wait, see if he gets back on, and I will make sure to collect your questions, and I'll send it to him and get the answers, and later we can post it on our Facebook page. So please take a note of our Facebook page and visit us back for the answers of your questions. I will put the information in the chat. So let's wait a little bit. Thank you.
Facebook.
He did a wonderful job. It was very informative. It was very user friendly, very understandable. So thank him.
I agree. I will do that. Thank you,
I
Kathy.
think this is the smoothest one we've had up till now.
他是什么人呀？
我上一次那个也很好，
也很好的。
不上一次那个不是他们，再上一次也是他们，就每次都还不错。
上一次的不是他们啊，是
上一次
那个，
是另外一个
是不是那个？
hospital，
是不是 City of Hope？
yeah. That's it.
不要动，不要动，听他在 connect。你就是上一次早动了一下，然后就这个东西很 sensitive。
Hello there. Sorry about that. Connection dropped out.
Thank you for returning.
Yeah, let me know what's the next question. Happy to keep going here.
Good to have you back, Dr. Odell. Let me just check the question. I have been diagnosed with osteoporosis. Am I still a candidate for a knee replacement?
Yes, you are. Yeah, there's no reason that we wouldn't do a knee replacement. If you have end-stage arthritis and you have severe symptoms in your knee, you can still have a knee or hip replacement with osteoporosis, and still a very safe procedure for you.
Thank you, Dr. Odell. What are the differences between anterior versus posterior? I had to do posterior and taking 1.5 years to finally heal.
That's a little bit unusual. They're both great ways to do the surgery. I do them both. I do anterior approach and posterior hip approach. The differences are where we cut the body. So in the anterior approach, we're going through the front of the hip, and we go between muscles for the most part. In the posterior approach, it's called a posterior approach, but it's really kind of we make a cut on the side of the hip, and we do go through the gluteus muscle, and we have to detach a few small muscles from the back of the hip joint. But it's still a very reliable way of doing the surgery. Most posterior approach patients do very well. So they're both great ways to do the surgery. The anterior approach is kind of becoming more popular among surgeons and patients recently because it does avoid. It's a muscle sparing approach. We don't have to go through a muscle. But really, hip replacement's should be a successful operation either way. So it's a little bit unusual to have that long of a recovery. But,
Thank you, Dr. Odell.
Yeah.
Here's a follow-up question to what it was a question earlier. It was about interpreted as plantar fasciitis, and that is not the issue. And the audience says the pain and the stiffness is in the tissue that stretches across the tops of the feet. So could you explain
yeah,
a little bit more about that?
Yeah, so pain across the top of the feet, sometimes that can have a few different sources. It's hard. I'd have to do a physical exam and potentially take some x-rays to figure out exactly what was going on and the source of that pain. Sometimes that can be from a nerve, or could be from tendinitis. So I'm not certain about pain across the top of the foot. Sometimes it's related to inappropriate footwear. But yeah, I'd have to probably do a physical exam and get more detailed information before talking about that one.
Thank you, Dr. Odell. And we're wrapping up with one last question here.
Sure.
And that is, do you have comments about collagen supplements?
So I mean, those you hear about those collagen peptides; those are becoming more popular and being marketed. And I've read some. There are some scientific studies that show that they improve joint comfort. But as an orthopedic surgeon, and coming from kind of going along with the Orthopedic Academy, we don't recommend for or against collagen peptides just yet. But again, there's something that's safe. They're hydrolyzed proteins. They come from their kind of the constituents of collagen. And some patients do think that they help with their skin and hair and joint comfort. So it's something to try. If you can, they're expensive. You can afford it, and if you can afford it and you want to try it, should be totally safe. And but as surgeons, not something that we really recommend strongly or for.
Well, thank you very much, Dr. Odell.
Hey, can I ask my question?
Oh, I'm so sorry, Kathy. Yes.
I'm scheduled for a partial knee replacement. You can ask. I'm afraid to ask them.
No, go ahead. I didn't go through partial knee replacement, but that is a you have a more specific.
Well, I have a partial knee replacement scheduled in August, and how do you? I don't know. I'm hoping it goes well. It better go well.
So partial knee replacement didn't include that in this talk. But that's a very successful surgery. Very successful surgery for the right patient. So I have a pretty narrow indication, or a very specific patient that I want to do a partial knee replacement for. And that's a patient who has pain on only one side of the knee. If someone comes into me and they have kind of pain in the back, the front and the side of the knee, and then they have arthritis on the x-ray in more than one spot, usually a total knee replacement is a more reliable procedure. But the partial knee replacement, if you have arthritis that's really isolated to only one side of your knee, and you have symptoms that are isolated to one side of the knee, meaning the inside or the outside, probably the inside is where your pain is.
That's true.
Very successful procedure, and potentially a much easier, generally an easier recovery than a total knee replacement.
Well, thank you.
So hopefully it's a good procedure for you. There is a risk of that the rest of the knee, when you do a partial knee replacement, the rest of the knee can become arthritic and may require conversion to a total knee replacement in 10 to 15 years, but that's not the case for all patients. But
thank you.
Depending on the age you are, when you're getting that surgery, changes whether or not you'll need a secondary surgery down the line.
Hopefully not.
Great option. Hopefully not. Great option.
You did a great job.
Generally a great option. Okay, thank you.
Thank you,
Very
Dr.
informative. Very where you can understand it on a public knowledge form. So thank you. Take care. Thank you, Faye.
Thank you,
Our
Kathy.
next one
Thank
with
you, Dr.
Methodist.
Odell.
Our next one, Methodist Hospital, is on Thursday, September 30th at noon on our anterior fibrillation. I can't say that very well. but it is
Sure.
Dr. Susie Lee. So maybe, Faye, do you want to explain that virtual seminar?
Oh yeah, Kathy, thank you. Yes,
Thank you for having me, and
Thank you.
Thank you, Dr.
If there's any
O'Dowd.
questions, you can feel free to email me. All right, have a good weekend. Bye-bye.
September
You
Thank
30,
you,
take care.
Dr. O'Dowd. Take
Thank
care.
you.
What?
Thank you so much for your
September
time.
30他们又有一个
And
seminar。
yes, so to echo what Kathy just announced, we have a lecture on aerial fibrillation in September, and it's with Methodist Hospital's cardiologist, Dr. Susie Liu. So make sure check out our website calendar for our upcoming events and details on how to register. And then also, thank you so much for joining us. And we also encourage you to check out our OrthoCare website. We have a lot of information about the care, about orthopedics at Methodist Hospital. So we'll put that in the chat, and feel free to send us comments on Facebook. The video of this lecture will stay on Facebook if you like to rewatch, or share the link with your family and friends who might be benefit from Dr. O'Dowd's lecture. So we hope this lecture is helpful for you, and we hope to see you at our next talk. And thank you, everybody. Have a great weekend. Thank you, Kathy.
反正你等
Thank
等
you,
到回去
Diane.
听得到。 September 30好像。
Take care, Kathy. I'll see you.
Thank you. Yeah, hopefully I'll see you soon.
Yep, see you soon. Bye-bye.
Bye-bye.
OK， 现在要怎么样？我忘掉了。在哪里有 Command Shift 5， 然后再 Stop Command Shift， 你按了吗？然后就是这个